Thank you, Mr. Chairman, for this nice introduction. I would like to thank the organizing committee to have me today to be a part of this scientific program. As we know, every problem in the world has a solution if it is evaluated correctly in the right way at the right time. So our problem today is about constipation, or basically chronic constipation. So we'll find a way to assist to achieve success eventually. This is my references, and I have no disclosures. In coming 15 minutes, I'll be talking about the definition of chronic constipation, type of constipation, how to approach patients with constipation, testing modalities, and management. American College of Gastroenterology and American Gastroenterology Association define constipation as unsatisfactory defecation characterized by infrequent stool, difficult to stool passage, or both, although physician often regards constipation to be synonymous with infrequent bowel movement, typically fewer than 3 per week. But usually the patients have a broader set of symptoms, including difficult stool passage, includes straining, a sense of difficulty in passing stool, incomplete evacuation, hard lumpy stool, prolonged time to stool, or need for manual maneuver to pass stool. Room for criteria for diagnosis of functional constipation, the onset of constipation, symptom at least 6 months before diagnosis, and the criteria must met for the past 3 months. 2 or more of the following criteria must be present at least more than 25% of defecations, straining, lumpy hard stool, sensation of incomplete evacuation, sensation of anorectal obstruction, manual maneuver, by digital evacuation, and fewer than 3 spontaneous defecation per week. Also, loose stool are rare without administration of laxative, and insufficient criteria for irritable bowel syndrome. It's usually a common problem. It's around 10 to 15% of the population. It's really costly. It's a high burden on the society and also on the patient, as we find patients roaming from hospital to hospital, shopping from doctor to doctor to get satisfied, but unfortunately they will not. It's associated with significant decrement health-related quality of life, subject to significant misconception by the patient or caregivers and providers, variable in their presentation and description by the patient, is a potentially complex disorder comprised of multiple etiologies, and really it's a manageable problem if it's correctly evaluated. This is the causes of constipation. We have a huge list of causes. We have the no gross structure abnormality or functional causes like inadequate fiber intake, irritable bowel syndrome, idiopathic slow transient constipation with pelvic floor dysfunction. We have also structural disorder like anal fissure infection or stenosis, colon cancer, abnormal colonic muscle. Also, we have the neurological causes like diabetic autonomopathy, spinal cord damage or diseases, Parkinson's disease, endocrine or metabolic causes like hypothyroidism, hypercalcemia, porphyria, or pregnancy. Psychological disorder also, we have a depression, anorexia nervosa, denied bowel habit. Side effect of medication, and the most common side of medication that induce constipation, we have opioids, calcium channel blockers, anticholinergics, we have tricyclic antidepressant medication, and oral irons. How to approach those patients? So we'll ask the patient about the duration of the symptoms, patient definition of constipation, antecedent events, a combined symptom with IBS or chronic idiopathic constipation, details about the stool, bowel habit, medication, diet or meals, previous investigation or procedures like constipation, like colonoscopy, comorbidities, and use of laxative. In examination, we are looking for the previous surgical scars, abdominal distension, and bowel sound, palpable masses, anal inspection for tag, fissure, or hemorrhoids, rectal, vaginal examination, and neurological exam. We have the subtype of chronic idiopathic constipation. We have the first type is normal transient constipation, with the most common subtype of functional constipation, although the stool passes through the colon at the normal rate, but the patient usually find it difficult to evacuate their bowels. Patient in this category, sometimes they meet the criteria for IBS with constipation. The primary difference between chronic constipation and IBS-related constipation is the prominence of abdominal pain or discomfort in IBS, patients with normal transient constipation usually have normal examination. Slow transient constipation is characterized by decreased colonic mortality leading to infrequent defecation, a clinical history of less than 2 defecation per week, more in female, laxative dependent. Patients with slow transient constipation had impaired basic colonic motor activity, so they may demonstrate some mild abdominal distension or palpable stool in the sigmoid colon. The third type is functional defecatory disorder. We have dysenergic defecation. It's a pelvic floor dysfunction or dysenergia characterized by paradoxical contraction or infrequent relaxation of the pelvic floor muscle during attempt defecation. The use of digital maneuver to induce defecation usually suggests dysenergia. We have also the inadequate defecatory propulsion characterized by inadequate propulsive forces during attempt defecation. Digital rectal examination is very important to evaluate the resting and squeezing anal tone, abdominal wall contraction, and the ability to relax the anal sphincter and push the examiner finger out of the rectum. General management and basic workup. So we'll send patient blood tests for CBC, glucose, thyroid, and renal function. We perform colonoscopy in patients older than 50 years or if any alarming features for colon cancer like rectal bleeding, anemia, weight loss. We try the first line of treatment like stool softener, high fiber diet, osmotic laxative, and stimulant laxative. We consider perisecretory agent and novel other treatment as a second line of treatment. Diagnostic testing indicated for patients with not responding to different treatment modality or develop more symptoms, patients so suspecting anatomical changes acquired or inherited, if colonoscopy performed was not conclusive with no improvement. Anorectal manometry, it's to assess the internal and external sphincter, rectal pressure, and rectal reflux. And the main abnormality in patients with dysenergic defecation is the demonstration of less than 20% relaxation of the sphincter pressure during attempt defecation with adequate rectal pressure. Some patients have paradoxical and anal contraction with attempt defecation. In this figure, we can demonstrate the finding of the manometry. So in figure A, we have the rectal and normal rectal pressure and normal anal pressure. In figure B, is dysenergic defecation. We see here the decrease in anal pressure with normal rectal pressure. And dysenergic defecation, we have paradoxical anal pressure with rectal pressure. Balloon expulsion test measures the time that it takes patient to expel 50 ml of balloon from the rectum, and the normal time is less than 1 minute. Abnormal balloon expulsion test suggests abnormal defecation, but not providing another information about the underlying pathophysiology. However, it's a good screening test for defecatory dysfunction. Also, we have a colonic transient test or SITS mark test. It's a capsule containing radio-obic marker. We'll ask the patient to swallow the capsule and to avoid any laxative during this study. We'll ask the patient after 5 days to do chest, abdominal X-ray. 6 or greater of this radio-obic remaining in the colon suggested delayed transient constipation or dysenergic constipation. So the location is very important. As we see here, in figure A, it's normal. So we have the radio-obic marker less than 5. In figure B, we have slow transient constipation, and the marker is distribution throughout the colon, and the dysenergic defecation. All the marks collected in distal colon or rectum. Wireless motility capsule, it's a smart pill. It has a sensor to measure the temperature, pH, and pressure. It's measured all the gastric emptying time as well as the large and bowel transient time. This study is to assess the slow transient constipation, and this FDA approved for this indication since 2006. It's helpful to ruling out gastroparesis and small bowel dysmotility prior to elective colectomy in patients with severe constipation. Management of mild symptoms of chronic idiopathic constipation will ask patient to take high fiber intake, exercise, adequate hydration, toileting behavior, also pharmacological agent, stress reduction, and over-the-counter laxatives. This is the American Gastroenterology Association recommendation for over-the-counter laxative for chronic idiopathic constipation. We have polyethylene glycol with a strong recommendation and high quality of evidence, lactulose, strong recommendation, high quality of evidence, and we have bisacodyl, strong recommendation and moderate quality of evidence. This is the approved agent for chronic idiopathic constipation. This is the second-line management of chronic idiopathic constipation after exhausting all the resources for treatment of the constipation. So we have this lobiprostol. It's a prostaglandin derivative, increase the intestinal fluid secretion and motility by activating the chloride channel at the apical membrane of enterocyte. It's approved for treatment of chronic constipation, idiopathic constipation by 24 microgram twice daily with food, aiming to reduce the nausea, and for IBS, 8 microgram twice daily. Side effect is nausea around 30%, is dose dependent, diarrhea 10%, and headache is 7%. And this RTC, we have twice daily doses improve the chronic idiopathic constipation and related symptoms for short term, for weeks, this against placebo. Linaclotide is a guanylate cyclase C agonist acting in chloride channels at the enterocyte apical membrane. Dose is 72 microgram and 145 microgram once daily, 30 minutes before food. It's also approved for IBS-related constipation with 290 microgram daily. Side effect is diarrhea, abdominal pain, and flatulence. And this RTC also once daily of 72 microgram or 145 microgram is significantly improved the constipation and related symptoms for 12 weeks in both men and women. Placnitide, it's relatively new medication, is a guanylate cyclase C agonist acting in chloride channel and at the enterocyte apical membrane. Its dose is 3 milligram once daily with or without food, as well as it's for IBS with constipation, 3 milligram once daily. Side effect is diarrhea 4 to 5%. Also in this RTC, significantly improved the constipation and related symptom with low rate of adverse event with dose of 3 to 6 milligram versus placebo for 12 weeks. We have the prokinetic agents, procalpride. It's a serotonin 5-hydroxytryptamine 4 agonist, approved for chronic idiopathic constipation. The dose is 2 milligram once daily, and patient with creatine clearance less than 30 ml per minute is 1 milligram once daily, as well as for elderly patient above 50. And this RTC is shown also improved bowel function and decreased symptom with severe chronic constipation. Side effect is headache, abdominal pain, nausea, and diarrhea. Biofeedback for the synergic edification is a process in which person learns to influence body responses through the use of feedback cues, ultimately leading to the correction of maladaptive behaviors. The preferred treatment for pelvic floor dyssynergic required 4 to 6 sessions. The treatment goal is correct coordination of abdominal and pelvic floor muscle during evacuation and improve perception of rectal filling. In this study, they recruited 52 patients receiving 5 weekly biofeedback sessions. So the efficacy is more than 70% superior to the other modalities with long-term benefit for more than 2 years. The success depends on the patient motivation and skills of the therapist. Acupuncture also showed that good result in treating severe constipation and related symptoms, especially continuous spontaneous bowel movement, and the result more higher with younger age population. Gynecological input, urinary and pelvic floor symptoms like pain may frequently coexist with chronic idiopathic constipation. Most effective strategy, multimodal approach combining physical therapy with myofascial release, home exercise, direct injection to trigger points, intravaginal anxiolytic, and Botox. Psychological adjuvant therapy.
You've got 2 minutes more. You can, if you want to finish. It will appear after a few seconds, yeah, I think so.
So this is the evidence-based psychological strategies for functional gastrointestinal diseases. We have hypnosis, exposure therapy, cognitive behavior therapy, mindfulness, meditation, relaxation training, and psychodynamic interpersonal therapy. This take-home message, so chronic idiopathic constipation, a common GIT problem that's not adequately evaluated. Chronic constipation is highly prevalent, reduces patient quality of life, and imposes significant healthcare burden on the society. It can hide serious medical problem. Proper evaluation by history, examination, investigations, including specific tests for studying chronic colonic transient and action of defecation, if applicable, is required for effective management. Lifestyle modification and over-the-counter agents improve the symptom of constipation in some patients. However, many patients have persistent symptoms and require use of prescription medication. Polyethylene glycol is used as a treatment, is the treatment of choice for chronic constipation as a first-line treatment and is effective, resolving fecal impaction. New pre-secretory agents have proved to be effective and safe for treatment of chronic idiopathic constipation and IBS-related constipation. Biofeedback therapy recommended as the first-line treatment for patients with dyssynergic defecation. Many modalities like psychological acupuncture are very effective and help to improve the patient constipation and well-being. Thank you for your patience, and by that I conclude my presentation.